there are two kinds of treatments for this. In this brief lecture, we covered the replacement for thyroid deficiency. Obviously, if it is deficient, self-evident that you give thyroxine. Not daily, mostly levothyroxine, but essentially weekly. Antagonism of excess thyroid hormone production, you have to use antagonist of multiple steps of T4 and T3 synthase. There are several drugs which can be used for this, and the most important is metimazole and thyroid uracil. Others are less frequently used. And our pharmacist colleague, Dr. Rose Begari and Cheng, will cover these two drugs also, and they will emphasize that only one of them is safe in pregnancy. So, just a quick review that the complex interactions is not only TSH affecting thyroid, but there is another influence from stress on the thyroid function production. So here is a very simple summary which implies drug controls of pharmacological implication. So how you start? As I illustrated in previous presentation, iodine is taken up from the blood and essentially transferred in the follicular cells and pushed into the colloid. Again, this pink fluid in the center of follicles are not inactive compounds because here a lot of metabolic function are happening. Using thyroids and residuases, iodine is attached, and the attachment is controlled by propyltyrosine and metimazole. So you can control this site of action of the most frequently used antithyroid drugs, PTU and metimazole. Essentially, after iodation, binding the protein, essentially released in the circulation, either under T4, when there are 4, iodine 1, 2, 3, 4, or 3, thyroid 1, 2, 3. So these are all tyrosine derivatives carrying either 3 or 4 iodine, and easily manipulated by PTU and metimazole. So the pharmacologic targets, of course, is self-evident. Are the replacement for thyroid hormone deficiency or antagonist of excessive thyroid hormone production in Graves' disease and other. And these antagonists act at multiple steps, but the most important in the pharmacologically is these two steps. What PTU and metimazole does, or the percolate thiocyanate and perfect effect, which affects the uptake of iodine by inhibiting this potassium iodine transporter in the follicular cells.
So is that PTU is using for hypothyroidism, not hyperthyroidism?
Hyper, because PTU and metimazole are shut down thyroid hormones, so they are used only in Graves' disease.
So this is
Hyperthyroidism. In hypo, when you don't have enough thyroxine, you don't dare to eat it because you need the replacement. So these drugs are used mostly for Graves' disease. And again, the most important PTU and metimazole. Other potential interaction, but here it is the conversion of T4 to T3 is inhibited by PTU. This is your major target. Again, you do this only when there is hyperfunction, such as Graves' disease. So here is a summary also what you do with the hypothyroidism. In replacement therapy, either T4 or T3. Please remember that because of the long half-life of T4, this is essentially thyroxine acts as a depot in the treatment. But the T3 is the metabolically active. Again, a reminder, T3 is 1 day, 18 to 24 hours half-life. T4 is 4 to 5 days, 6 days. thyroxine has L-isomer of T4 is the treatment of choice for mixed edema because it's hypothyroidism. You have to replace thyroxine. But watch out for drug interactions. The sodium polystyrene, sulfonates, cholestyramine, and the metabolic effect of rifampin and phenytolamine. And all this, again, a reminder for the demonstration of mixed edema. But essentially, if you give levothyroxine once a week, this can be essentially monitored for a long time. The opposite of this is the hyperthyroidism called Graves' disease. Again, the reminder from the previous illustration. There are a few interactions here. The inhibitors of iodine uptake, this sodium and iodine transporter, anions with similar atomic structure can inhibit this. The most widely used are the perchlorate, thiocyanate, and beta-cares. But this effect is not immediately apparent. Why? Even if you import the iodine into follicular cell, why cannot you see an effect immediately? There's a reduced thyroxine formation, but nevertheless you don't see the effect very quickly. Why? It comes back to the half-life of thyroxine. How long thyroxine remains in the body? A week. Thyroxine, long half-life, sitting in the body. So even if you start to inhibit synthesis of thyroxine, it is not immediately effective. And that's what is the Graves' disease. You can give this perchlorate thiocyanate, but not as active, immediately active, because they just inhibit the synthesis of thyroid hormone, thyroxine, in the gland. Much more important to use inhibitors of T4 synthesis and release, especially the conversion of T4 into T in the periphery by dynamides, epityrosine, metimazole. So these are your most important particles. And this can be used, these patients can be treated for a long time for these two drugs. If they don't respond to this, then you have to the big guns, radioactive iodine, which is a beta emitter toxic to the cells. But I mentioned previously that it's very tricky to with any dose. If you give too much radioactive iodine, you destroy too much of thyroid gland and causing Hashimoto's hypothyroidism. So much better to use propylthyroxine and metimazole because these are easily measurable and controllable. Radioactive iodine is the last option for this. Again, know that while the synthesis of thyroid is not active immediately because of the long half-life of thyroxine, which is already in the circulation. So what are the inhibitors of peripheral thyroid hormone conversion metabolism? Most important is again the inhibition of the peripheral 5-deiodinase, PTU, and beta-arginine blockers, especially for tachycardia. S-mono, which has extremely short half-life, and you have to know this because this is a life-saving intervention in the colon of thyroid stone. Act immediately, and thyroid stone, when the hyperthyroidism, Graves' disease becomes so severe that you have to do something. Of course, radiation would not come into effect. You need a chemical inhibition, and S-mono is the fastest acting drug. Corticoids can be used also, and iodine restricted. Lithium selectively concentrated in the thyroid glands and inhibits the release of T4 from the follicular cells. And the tyrosine kinase inhibitors, such as sunitinib, can cause hypothyroidism very easily. It could be bypassing essentially. Multifunctional mechanism monitor thyroid function of hormones because some minor effects of this additional effect of tyrosine kinase inhibitor. Here is another important information about the two most widely used anti-thyroxine drugs, metimazole and PTU. This is an illustration of euthyroid, normal thyroid function restoration. Metimazole acts much faster than PTU. Eventually, they can all reach normal function of the thyroid, but takes quite a few weeks. 10, 30 weeks, so it has to be titrated out. The other important implication that all these drugs are undergoing transformation in the liver, and especially phenytoin, phenobarbital, rifampin, essentially induce cytochrome P450 and accelerate the metabolism of T4, T3, and the metabolites will be less active. So not only to control thyroid gland, but watch out for other drugs which affect the metabolism of these drugs. So the summary of all this is that the hypothalamic pituitary thyroid axis is not that specific because the adrenal gland also affects this. The simple pharmacology of thyroid disease is really simple. Because if you have thyroid insufficiency, you give replacement therapy by thyroid, levothyroxine. If it is excessive hormone production, you try to antagonize the excess, either inhibiting the synthesis of thyroxine or much faster inhibiting the peripheral conversion of T4 to T3 by propyltyrosine, PTU, or metimazole. So you have two options: treatment for hypothyroidism, for Hashimoto thyroiditis, or treatment for hyperthyroid disease. And watch out for drugs for thyroid diseases, how they're affected. Iodine and potassium iodide, levothyroxine, liothyronine, litoxin, and the most important among all these is, of course, metimazole and PTU. Any questions from